Before the COVID, our ICU has 52 ICU beds for adult patients and 16 ICU beds for pediatric patients. These are all equipped with centricity critical care. So due to the COVID crisis, we increased also to the post-anesthesia care unit. We increased the number of beds there, and also the coronary care unit as well. We did not want it to go back on paper as we did many years ago, because by using the digital system, we could keep an overview of our patients, not only for hemodynamics and ventilation and infection, but also for the status of the COVID parameters as well. So we kept a very good overview over all parameters by using the digital system, also in the other wards, in the post-anesthesia care unit and the coronary care unit, where our normal ICU patients were located. It's more or less the same as the normal ICU patient. That's my impression. But we also installed an additional trend graphs. So we created special trend pages in order to have a big overview, a great overview for the patients, not only for the normal parameters, for hemodynamics and ventilation and infection and liver and kidney function, all these things. But also we included specific sections for COVID parameters like ferritin, LDH, eosinophils, and also we included the view in the trends of patients being prone or being on ECMO. So that was something we previously did not include it into the trend pages, but we included it from the start of the COVID pandemic in order to have a big, nice overview of which patient was prone and then additionally on ECMO and then afterwards weaned from the ventilation. So we had a big overview, a great overview on these patients, because we are on duty for all these patients with one or two at maximum senior staff members at night or at the weekend. So if you have 40, 50 patients or more on ventilation, it's impossible to have a great overview of these patients if you don't have digital solutions. Most of my colleagues agree that working for COVID patients was more stable than working for the most critically ill patients. Because they were used to working with a system that was nothing different than before. And COVID patients are very similar in their clinical course. They are difficult to ventilate. They get prone ventilation, some get ECMO ventilation, but it's mostly a ventilation problem and a sedation problem. Some of them have also kidney problems, but we didn't see that very often. But that's the main course in these COVID patients. And because we were used to working with the digital system, we didn't have extra burden on working with these new kind of patients. So we had all the time and the possibilities to focus on the treatment of the patient and not on being able to have an overview of these patients, because we were used to the system as well. We need a lot of data to be able to answer unresolved questions in the ICU. So I'm a big fan of using ICU data for predictive modeling, prognostic modeling. The question is how we're gonna use this data, knowing the GDPR rules and be compliant in using these GDPR rules. There's also the fact that we have a lot of structured data, very granular structured data, but we also have a lot of unstructured data, which is not being used very extensively because we don't have the exact tools or the right tools for now. So I really hope that in the near future we will be able to use this unstructured data as well, and in that way have a more broader database for using this for predictive modeling. I would advise these hospitals to start a transition to digitally as soon as possible. It is my real conviction that using digital solution for the ICU is the best way to improve the quality of care of your ICU patients. If you don't use digital solutions for your ICU, you don't have the broad overview that you need to treat those patients the best you can.